Thank you for downloading Children's Pedcast, a conversation about pediatrics with Children's Minnesota. My name is Jimmy Bellamy, and this week my guest is Dr. Laura Gandrud of the McNeely Pediatric Diabetes Center here at Children's Minnesota in St. Paul. And Dr. Gandrud and I talk about the misconceptions people have of diabetes, the differences and the similarities between types 1 and 2. And we talk about the factors in developing type 1 diabetes. We talk about the Diabetes Care Transformation Project, which is a current study that Children's is leading that involves technology and teenagers and the monitoring of their type 1 diabetes. And we talk about the upcoming STAR Gala, which is the 25th annual event Children's is having on April 16th. This year's gala supports the Diabetes and Endocrinology program at Children's Minnesota, and we're excited about the possibilities and potential of the work being done around type 1 diabetes care and what's being done here at Children's Minnesota. You can find us on the web at childrensmn.org. We're on Twitter at childrensmn. And you can find the podcast on iTunes, Podbean, Stitcher, Spreaker, YouTube, and Vimeo. Or even just do a Google search and you'll find us. Here is an episode on diabetes with Dr. Laura Gandrud. When I hear diabetes, I think what I think a lot of people do is you picture somebody who's either overweight or irresponsible with his or her diet. And that I think may be a lot of people's vision of diabetes, not knowing that there is a difference between type 1 and type 2. Is that one of the hardest things you guys deal with on a daily basis, is people's misconceptions of it?
The hardest thing I would say in my discussion with adolescents who have type 1 diabetes is that misunderstanding. They feel like they're always misunderstood and that people look at them and feel like it was something they ate or something they didn't eat or their level of activity that was responsible for the disease that they're dealing with. And that, I think, is a common frustration for them.
Are there conditions that people are predisposed to, that whether it be heredity or something genetic where you're born with it, or are there any factors that can indicate how you're going to develop it in the future? So
diabetes is kind of a classic disease that is caused by both genetics and environmental factors. So we know that they're genetically vulnerable individuals due to a whole host of genetic factors that they have. It's not a single gene defect where you obtain one abnormal gene from mom and one abnormal gene from dad, but it's a whole host of genetic factors that makes that individual vulnerable to developing diabetes. Then there are triggers or a combination of triggers in the environment that then lead to the development of diabetes in that vulnerable patient or person. What we know from identical twin pairs is not all identical twin pairs will both twins have diabetes, and that speaks to that environmental trigger or combination of triggers. We don't know exactly what those are yet, but we do know that it's a combination of both genetics and environment.
Okay. And is there any way to be in the clear as far as I'm 34 years old, so there's no chance I'm ever going to get type 1 diabetes? Is anybody ever safe from it? That's not the right way to put it. Are you safe from it? But are you ever not capable of developing it?
Type 1 diabetes can essentially occur at any age and develop and be diagnosed at any age. We've had children less than a year of age who've been diagnosed with type 1 diabetes, and it is felt that they have a very aggressive autoimmune form where their beta cells are wiped out fairly quickly. And there are reports of people in their 80s being diagnosed with type 1 diabetes. So it really spans all ages.
When it comes to the work you guys do at the McNeely Pediatric Diabetes Center, what are the largest hurdles, either traditionally or currently, to getting compliance from kids with diabetes? And I know that you have a range of everything from infants to teenagers. I'm sure they differ. I'm sure the factors are different, but what are some of the things that you run into on a regular basis where Is it people not taking the consequences seriously, so they're not keeping up with the monitoring?
Well, historically, the data shows that the poorest diabetes control is generally in our adolescents. So that's the population that first comes to mind when I think of challenges or a challenging group in general. As you alluded to, there are challenges in each age group, but I think in the adolescents, what we struggle with frequently is a buy-in and an ability to manage this very complex disease despite all of the other things going on in their life, and that long-term consequences are not at the forefront in their daily life. So that can manifest as either not testing their blood glucoses as routinely as they need to, not taking their insulin when they need to, not letting their parents know when they've had elevated blood sugars or feeling unwell. So there's a whole range of kind of issues related to the fact that they have a million things on their plate, and they're dealing with homework and stress at school and friends, and what are they going to do when they leave high school. So it's a really difficult and challenging time, in particular in that age group.
So currently we have the Diabetes Care Transformation Project. What led up to that? What did the first study look like?
So we conducted a feasibility program with 6 adolescent girls with type 1 diabetes, in order to see if there was any way that we could motivate improved compliance with their diabetes regimen, and motivating them through new technology, or technology that they're using with new software. So what we did is we recruited 6 subjects, and this was just a program that they chose to participate in. It's not an IRB approved study, or it wasn't, we're not specifically publishing the results. But they chose to participate in this feasibility program, in which we allowed them to use a nice phone, a Samsung S6 or an iPhone 6. And we asked them to test blood glucoses at certain times of the day based on their schedule. So we sat down with the teen and their parents. We went through their daily schedule on Monday, Tuesday, Wednesday, Thursday, and so forth throughout the week. If they were only testing 2 times a day, we aimed for a target of 4 tests a day. And just to know that the minimum amount of tests that we recommend is 4 tests a day. If a child can do 5 or 6 tests a day, that's even better, because we know that control is correlated with the number of tests a person does each day. So we were really addressing the first step in improving control, which is increasing blood glucose testing frequency. So we set a goal for them, and we worked with them and their parents to decide how they would meet that goal throughout the day. We would send them a reminder text via their phone that we gave them to test their blood sugar at the start of the testing time. When they tested their blood sugars, they used a new form of technology to upload their glucoses to the web, which allowed us to see that, yes, indeed, they had tested their blood sugar at the appropriate time. If they hadn't tested their blood sugar within the appropriate time, we would shut their phone down, such that they were only able to call 4 predetermined numbers: mother, father, 911, and the study coordinator. And what we found was that we were indeed able to motivate increased testing, which again is kind of the first step towards improving blood glucose control and diabetes control.
And that was the first study?
That was the first study.
And how did it look result-wise? Or I shouldn't say that. How long did it span?
So the study spanned about 6 months. It was very well accepted by the adolescents. We had a little concern that they might lose interest or find that it was frustrating to them, but they all agreed that it was absolutely motivating to them, and it was a great support to them. And the interesting thing that we found was that it helped improve the teen-parent relationship. So these teens were being supported by someone other than their parents and asked by someone other than their parents to test their blood glucoses. So they found that at the end of the study, what they were most saddened by at the end of the study was the fact that they were losing that support that they had during the study. It wasn't the phone necessarily. It wasn't this fancy phone that we had given them. It was really the study coordinator who was in touch with them and reminding them to check their blood glucoses.
Was that an unintended result as far as, or maybe not unintended, but unexpected? And what does that say?
Yeah.
I understand teenagers, you know, I remember vividly, you have those battles with mom and dad, sometimes over no reason at all. So I can imagine having that third party as maybe a shoulder to lean on. Is there something that now, because of this study, will change in maybe adjusting the care structure for teens?
Yes, certainly. I think that we do have to recognize, and this has been demonstrated, that tension between child and parent really hinders adequate diabetes care. And if we can find a way to, in a cost-effective way, to easily help with those diabetes care, to lessen the tension between teen and parent, that would be great. And I think we can use new technology to do that. I also think that what we learned is an automated system is maybe not, a depersonalized system is maybe not the best way to approach a program in teens. That if there's some recognition that there's a person involved in that program, that can be helpful, that they identify with that person and they develop a relationship with that person. Our study coordinator laughed a bit in that the texts that she was sending to these teens were very basic. They weren't involved or very detailed, but they still identified with her as the person sending all of these texts.
Interesting. And I know oftentimes the burden traditionally has been so heavily placed on the patient, on the person with diabetes. This is kind of swinging it back in the other way, taking a lot of that off and really involving family and friends, teachers, people involved in the child's life. What is the current project doing, and how did that come to be?
Mm-hmm. So I think you make such a great point about how so much of the responsibility is placed on the child's shoulders and on the family. And in speaking with families, they will tell you how it can be very lonely, and they feel isolated, and they're making all of these decisions daily, multiple times a day, about their child's diabetes, or the child is making multiple decisions about how to manage their diabetes. And it's very isolated from the care team. The traditional model is that when children have diabetes, they're seen in our clinic every 3 months. And we look at their data, which is on their meters, which they've brought to clinic physically, and we make recommendations for change. And our families are always able to contact our clinic to speak to educators for dose adjustments or help with decision making, but that families, they're not calling on a daily basis or multiple times a day every time they need to make a decision. So we are seeing them for maybe 3 or 4 hours a year when they're spending hundreds and hundreds of hours managing their child's diabetes. So with that in mind, and with the knowledge that it can be really helpful in lowering the tension between teens and parents to have some additional support for these families on a more regular basis, we sought to see how remote monitoring could help these families. Remote monitoring refers to looking at the data remotely, which we're now able to get via Bluetooth-enabled devices to the cloud, and making recommendations more frequently than every 4 months, and providing that support more frequently than every 4 months. And that is how the next study, that's the foundation upon which the next study was based, was remote monitoring and really allowing the care team to move outside of the walls of the clinic, because chronic disease is not best cared for in an institution. it's best cared for in the child's home and in their own environment. And so we need to meet them where they are.
And traditionally, that's how it was treated or is treated,
Yes.
where people are having to make multiple visits. And it can be an inconvenience. It can be taxing. And I can imagine it can lead to, especially with the teen demo, saying, well, I'm just going to be a little laissez-faire about this.
Yeah. I think in general, when you talk to a lot of adults about their experience, as teens, they hated coming to clinic. It was their least favorite day of the year. And I can understand that. And so we want to, as I mentioned, meet them where they are and support them where they are in their environment. And diabetes is absolutely, I would say, the best disease for doing that, because there's so much data involved in the decision making, and we can now see that data with the new technology. So physically seeing them in clinic is not necessary for us to view the data and identify patterns and make changes to their care regimen.
So I want to go back to that first pilot too. I'm interested in it so much because the comment you made that it wasn't so much the phone, it was the human interaction from someone other than a parent. Did that at all influence what was done with the current study?
Yes, that's a great question. So there's a lot of efforts into using algorithms, computer, generated algorithms or computer-assisted trend analysis in diabetes, where a computer would look for trends in a child's glucose patterns, and a computer would make recommendations for change. And we all recognize that that's the most cost-efficient way to help improve insulin dosing in children. But what we feel strongly that communicating those changes to the family cannot be just a computer communicating the changes, that there really needs to be this clinic interface. There needs to be this personal interface with the families. There is no trust built in just a computerized message being sent to the family, that if it's coming from a clinic or coming from a coordinator or coming from an educator, that they're going to trust that those recommendations much more. So I think that was kind of our feeling, and that was definitely a conclusion from that first trial, is that there needs to be that human interface.
That's interesting. Are more and more clinics and healthcare systems picking this up, or is there some lag in the development of these new treatments as opposed to traditional?
Well, that's a great question. It really is related to how we are reimbursed for our services. So there's a lot of interest in remote monitoring. It's just how can it be done effectively and in a cost-efficient manner, basically. So in Minnesota, we do have the ability now to be reimbursed for telemedicine visits. So that will help move the model such that children don't need to be seen in clinic each time. And a lot of insurance companies are interested in more reimbursement based on results. So when we have reimbursement based on results, that will push and motivate more novel methods or more remote monitoring. So you're not seeing the child in clinic as much, but you are helping them in their home. So I would say that it's emerging, mm-hmm. and it's really going to be dependent upon reimbursement models and strategies.
We have Gala coming up, and it supports the diabetes and endocrinology program. Tell me about the work that's gone into not only just the past year of planning for everything here, but just what it means to be the central focus for this event, this annual event, and what it will do for this program.
Well, it's an absolute honor to be the beneficiaries of the Gala and to be recognized. And I think what I'm most excited about is the recognition of the importance in caring for these children with diabetes. I really feel so strongly that with all of the new technology available in our world and all of the technology that we use in our daily lives, that we need to do more for our children, our teens with type 1 diabetes. And this Gala and the proceeds from the Star Gala will really help our clinic explore how we can do that, because they spend more time caring for their diabetes and caring for their disease than many illnesses. It's a daily, relentless disease, and they do such a good job, and we need to give them more help.
I think that's the thing that people fail to remember, is that there's no real, I mean, you can ebb and flow in your levels, but it's always there. And it's not my diabetes went away for a couple of weeks. It's constant, and I can imagine it's exhausting for the kids and the families who are going through it. It's great that this program is being recognized in this way, and that these studies have been able to show improvement in the lives of these kids and these families. Are you seeing, as a side effect of it, of the technology, more of an appreciation or an understanding from the patients of the consequences if I don't do this? That it's not just, I'm locked out of my phone. It's that here are some potential things that can happen to me health-wise?
I don't have that answer yet. We'll have to see at the end of the study. I think that for the most part, we've gotten a lot of feedback that they enjoy the support of what we're providing when we're helping them with feedback on a weekly basis, but we haven't formally looked at the improvement in quality of life and their understanding of the long-term complications of diabetes. I think some of that is in part due to just brain development, and that may not naturally come until they're a little bit older. But but I think that, yes, certainly education is a part of our input on a weekly basis. And just appreciation of the support and recognition that they're not alone, I think, has been helpful.
What are some things you'd offer as advice to anybody listening, either who has a child with diabetes or has a child who recently developed type 1 diabetes? What are things you would tell this parent as far as those first steps, the things you would say even in that first appointment?
I would encourage the families to know that they're not alone and to seek out supports of people who have been through the same experiences they have been through. I think that they will be amazed when they look back a week, 2 weeks, a month later of what they've learned and what they're capable of doing. I think a lot of families feel overwhelmed, but for them to feel proud of themselves when they do reach certain milestones in terms of their management of their child's diabetes. I think there are amazing changes that will come to how we manage diabetes in the future, and I think that it's I have a very optimistic viewpoint about how their child's diabetes will be cared for in the future. And also, I try to remind families to see the resiliency of their child, and that their child will run around and play and do most, if not all, the things that they did before their child was diagnosed with diabetes, and that they shouldn't let diabetes slow them down, that we can help them and we can support them through anything their child wants to do or accomplish. Just a reminder to keep living.
That's good advice. How about the importance of giving the best care to a child with diabetes in hopes that one day they'll be in the best shape possible for when a cure does exist?
We know that a cure will come. It's just a matter of time. And as you mentioned, we do want to bridge the gap between now and when that cure comes and keep our children as healthy as they can be until then. We don't want them to be dealing with irreversible damage to their body that occurred from diabetes before the cure became available. We don't want them to be managing renal failure or eye disease or nerve damage when the cure does finally come. So we feel very strongly, especially with data from big studies in the United States showing that if we can improve their glucose levels now, there's a legacy effect that has a positive impact on their health even 10, 20, 30 years from now. So that emphasizes the need for us to really focus on the care that we're providing right here and now while we wait for that cure.
I had asked Abby Nelson and her parents, actually, I asked them when I interviewed them. For the listeners, Abby Nelson is one of our diabetes patients, and she does a great job in her care, and her family does as well. And what I asked her parents, Tom and Martha, was, what will you do on either day 1 or day 2 after a cure has been found? And Tom said he'll get rid of that drawer of diabetes supplies that they have, and they'll probably have a celebration. But what will you do if you're around for a day that there's a cure?
Oh, I would like to personally celebrate with each and every one of my patients. You know, the impact that would have for that child's family. I would want to celebrate with each child. I'd want to bring them in for a party, every single one of them, to our clinic.
But they hate going to clinic.
Yeah, well, this is the one visit that they would absolutely love.
Because a lot of people may not understand that there are 2 types of diabetes, and they're extremely different from each other. What are the differences between type 1 diabetes and type 2?
So I'll start actually with the similarity of both diseases, which is elevated blood sugar. But the causes of those elevated blood sugars are absolutely different in type 1 versus type 2 diabetes. Type 1 diabetes is an autoimmune disorder in which the immune system attacks the cells of the pancreas that make insulin. Those are known as beta cells. The beta cells are destroyed. The child or the adult does not make enough insulin to maintain normal blood glucoses in the body, and they require insulin therapy for treatment of their disease. In type 2 diabetes, the initial abnormality is resistance to the insulin that the body's making. So the body is not responding to the insulin normally, and because of that, the blood sugars rise. There are multiple modalities for the treatment of type 2 diabetes, including lifestyle changes with increased activity, dietary changes. There are a number of oral medications that are used for the treatment of type 2 diabetes, and in some cases, insulin therapy is needed as well. There is no cure for type 1 diabetes. There's no way to prevent type 1 diabetes. Whereas the onset of type 2 diabetes can be delayed or prevented by some medications as well as lifestyle changes.
Because there's a distinct difference between kids and adults. Kids are still growing. What are some of the differences in treating pediatric diabetes that don't exist with adult treatment?
Pediatric diabetes is always changing in that the child is growing. The child is going through puberty. The child does one sport in the fall, another sport in the winter, and a third sport in the spring. So there's very unique challenges in diabetes. We see increased insulin needs when the child's going through puberty and growing. We see increased insulin needs just as the child gets bigger. We see lots of differences in blood glucose responses to different activities. So a child may have very high blood sugars after getting off the ice when they're playing hockey, or very low blood sugars when they're swimming in the lake. So that there's a lot of variability in what children do, and they're not generally as in control of their schedule or have as much of a routine in their daily lives as an adult may. So it's tricky. It's very challenging. These activities of daily life for children can be very challenging for managing diabetes.
What do you do for kids who are fearful of needles, that they need to, I assume, get over that? How does that get handled?
We have an amazing team at Children's. We, for the most part, do all inpatient education at the time of diagnosis, and in part because we're able to support the family with all the services of the hospital that we have available. So we will generally have a child life specialist meet with the family, and they are amazing at providing strategies to the children and the parents for helping them get through that fear. And we encounter that not too infrequently, but they tend to recognize that it's just something that they need to do. And again, children and their resiliency and their ability to adapt always amazes me and impresses me.
You hit on two things right there. Resiliency, unbelievable. And two, the child life specialists. Yeah. I've seen it firsthand, and it's remarkable how they do it.
Yes, we are so grateful for their involvement in our patients' care. I appreciate the opportunity to speak about diabetes, and I think all of my patients, children, adolescents, appreciate people's attempts to understand their disease in more detail and recognize that there's nothing that they did or didn't do that caused this disease.
Thank you, Dr. Gandrud, for the time and for helping educate people about diabetes and pediatric diabetes in particular.